Last class, we followed a healthy meal from the mouth all the way down, and we talked about two things that protect you: the stomach's mucosal barrier and the liver. Today, we look at what happens when those protections fail. We'll cover the liver next class. Today is the stomach and the intestines. Start with the barrier. Your stomach makes acid strong enough to digest meat, and it holds that acid against its own wall all day without hurting itself. It can do that because a thin layer of mucus and bicarbonate covers cells that are packed tightly together. That's the mucosal barrier. Gastritis just means the stomach lining is inflamed, and there are two kinds. Acute gastritis is a short, hard hit from heavy alcohol, certain medicines, or a severe illness, and it usually heals. Chronic gastritis goes on for years, and it can cause anemia two different ways. First, years of inflammation destroy the acid-producing cells, and those same cells make intrinsic factor, which is what vitamin B12 needs in order to be absorbed. No intrinsic factor, no B12. And you need B12 to make red blood cells. Second, an inflamed lining bleeds a little at a time for years, draining the patient's iron. Two mechanisms, both leaving the patient tired. So what breaks the barrier? Two things cause most of the damage. The first is an infection called Helicobacter pylori, one of the few organisms that can survive in stomach acid. It burrows into the mucus layer and damages the barrier from underneath. The second is the anti-inflammatory pain relievers we call NSAIDs, medicines like ibuprofen, which block the signals the stomach uses to build and repair that barrier. One's an infection, one's a medication, and between them, they cause most peptic ulcers. A peptic ulcer is what happens when the barrier fails in one spot. Acid digs a crater into the wall of the stomach or into the duodenum, the first part of the small intestine. Where the ulcer forms changes the pain pattern, and that's useful to you. A gastric ulcer usually hurts more when the patient eats because acid is pouring onto an open sore. A duodenal ulcer feels better with food, then hurts again a couple of hours later once that acid moves downstream. Same disease, different location, and the patient tells you which one it is. Two complications to watch for. The ulcer can bleed, and that shows up as black, tarry stools, vomit that looks like coffee grounds, or just fatigue and lightheadedness in someone losing blood slowly. Or it can erode all the way through the wall. That's a perforation, and we'll come back to it. Now the absorbing surface. The small intestine absorbs nutrients through millions of tiny finger-like projections called villi. Think of a thick carpet. In celiac disease, the immune system reacts to gluten, the protein in wheat and similar grains, and attacks the intestinal lining. The villi flatten out, so the patient loses most of that surface. That's why you see weight loss, diarrhea, greasy stools, and vitamin and mineral deficiencies. Watch the mechanism here because your quiz asks about it. Gluten doesn't bind the nutrients and it doesn't push food through too fast. It sets off an immune reaction that destroys the absorbing surface. Take gluten out and the villi can grow back, which is why diet is the treatment. Inflammatory bowel disease is something different. It's chronic inflammation of the bowel that flares and settles over a lifetime, and there are two types to keep straight. Crohn's disease can show up anywhere from the mouth to the anus. It appears in patches with normal bowel in between, and it goes through the full thickness of the wall. That's why it causes strictures and fistulas. Ulcerative colitis stays in the colon. It's continuous with no skipped areas, and it only involves the inner lining. Because that lining is raw over a long stretch, it shows up as bloody diarrhea with mucus. Inflamed tissue bleeds easily, it produces mucus, and an irritated colon moves everything through fast. Don't confuse either with irritable bowel syndrome, which is a problem of function and sensitivity. The symptoms are real, but there's no inflammation and no visible damage. Sometimes the problem is mechanical. The bowel is blocked by adhesions from a previous surgery, a trapped hernia, a twist, or a tumor. Behind the blockage, stool and gas back up, and the bowel stretches and contracts hard against it. You'll see cramping pain in waves, a distended abdomen, vomiting, and nothing passing beyond the blockage. And if that segment stretches enough to cut off its own blood supply, the bowel starts to die, and now you're against the clock. Next, two problems that work the same way. A pouch gets blocked. The appendix is a blind pouch off the first part of the colon. Block its opening with hardened stool or swollen tissue, and secretions build up behind it. Pressure rises, blood flow drops, organisms multiply, and the wall gets inflamed. The pain moves while that's happening. A dull ache around the navel first, then sharp pain settling in the right lower quadrant, with nausea, a low fever, and a patient who doesn't want to move. And if severe pain suddenly goes away, that's worse news, not better. It usually means the appendix ruptured and stopped stretching, and the contents are spilling into the abdomen. Diverticular disease works the same way in a different spot. With age and a low-fiber diet, the colon wall pushes out small pouches at its weak points. Uninflamed, that's diverticulosis, and most patients have no symptoms. If one gets blocked and inflamed, that's diverticulitis, and it behaves like appendicitis on the left side, with pain in the left lower quadrant, fever, and a change in bowel habits. One pouch you're born with, one the colon develops. Same mechanism, same worst outcome. That worst outcome is peritonitis. The peritoneum is the lining of the abdominal cavity, and peritonitis means intestinal contents have reached it, from a ruptured appendix, a perforated ulcer, or a ruptured diverticulum. The presentation is dramatic. A rigid, board-like abdomen, pain with any movement, fever, and a patient lying completely still because moving hurts. It's an emergency for two reasons: the infection and the large fluid shift into the abdomen that can drop the blood pressure into shock. Last one. Most colorectal cancers start as polyps, small growths on the lining that take years to become malignant. That's exactly why screening works. Find the polyp, remove it, and the cancer never develops. Know the warning signs: blood in the stool, a change in bowel habits that doesn't go away, stools that get narrower, and unexplained iron deficiency anemia in an older adult. That last one is colorectal cancer until you prove otherwise. So here's what to bring with you. Helicobacter pylori and NSAIDs break the mucosal barrier. Pain worse with food points to the stomach. Pain a few hours after food points to the duodenum. Celiac disease flattens the villi. Crohn's disease is patchy and full thickness. Ulcerative colitis is continuous, superficial, and bleeds. Obstruction gives you cramping, distension, vomiting, and nothing passing below. A blocked pouch is appendicitis on the right, diverticulitis on the left. And a rigid, board-like abdomen is perforation with peritonitis, a surgical emergency. In class, we'll work through Mrs. Alvarez, who takes an anti-inflammatory every day for her knee and whose story starts with black, tarry stools. Finish the Module 43 stomach lessons and Module 44 before you come. See you in class.